Hello, welcome back. Today we're going to be going over an overview of the female reproductive system. This will prepare us for discussing some alterations in the female reproductive system later on. We will briefly discuss a little bit about males at the very beginning, but that will be content for a whole module of its own. So let's just focus on the female reproductive system mainly today. So here are our objectives. We're going to talk about different factors that promote sexual differentiation in utero, talk a little bit about puberty, diagram normal female reproductive anatomy. We will not be discussing breasts today. We may do that at a later time. And what we're really going to focus on is the menstrual cycle, the whole reproductive cycle, what is going on in the uterus and the ovaries. And we're also going to finish up discussing menopause and the physiological effects. So let's dive into it. So, when a baby is conceived, we get one copy of DNA from the mom, one from the dad. And you probably have heard this, but it is the sperm that determines the genetic sex. So that is actually something called the SRY, kind of looks like sorry, the sex determining region on the Y chromosome. The presence of that Y is what signals for that embryo to differentiate as a male. So a female is XX, a male is XY. So that happens right at fertilization. Between week 6 to 7 of gestation, we have gonadal differentiation. And gonads are something that secretes sex gametes, and it's the primary reproductive organ. So before differentiation, we have bipotential gonads. So two potential things. These are embryonic reproductive organs that are not male or female yet. And it's that sorry gene or lack of the sorry gene. I don't know if it's really called that. I'm just going to keep calling it that because it's just easier to say. And it's like a little funny to me too. To differentiate into male or female. And based on the presence or absence, at 6 to 7 weeks of gestation, either testes or ovaries are going to form. So, for those of you that have had a baby, or I know probably everyone listening to this has known someone who has had, we don't find out, if somebody decides to find out, we don't find out until, much later in the ultrasound. And I know that there are blood tests that can detect it, but really it's determined so soon in pregnancy. And then there's a little chart, kind of makes it a little more complex in what we're talking about, of how that kind of breaks down. So then we have endocrine differentiation. So in the males, the testes are going to be the primary endocrine gland that secretes those sex-specific hormones. Now, I do want to say that it's a little bit beyond the scope of this class or what we're going to be discussing. Testosterone is the male sex hormone, but females have testosterone as well, and males have estrogen too. So it's not just strictly one or the other, but for purposes of this lecture, we're just going to, stick to talking about each sex hormone, with who they primarily belong to. So in males, the testes produce testosterone, and that testosterone promotes development of something called Wolffian ducts, which then turn into the epididymis, the vas deferens, and the seminal vesicles. And also, the testes produce anti-Mullerian hormone, which causes Mullerian ducts to regress, so they go away. And if they hung around, they would form female structures. And then testes also produce dihydrotestosterone, or DHT, um, and that directs the formation of male external genitalia. So the penis, the scrotum, and the prostate. So in females, they don't have that, sorry, Y chromosome, and the gonads become ovaries, not testes. So there is a lack of anti-Mullerian hormone. So that means those Mullerian ducts hang around and develop into the uterus, the fallopian tubes, and the upper vagina. In the brain, um, later on in gestation, the fetal sex hormones influence brain development. So testosterone and estradiol, which is, kind of another name for estrogen, affect the hypothalamus and the limbic system. And it's the influence of those hormones that determines future sexual behavior and hormonal regulation. So it really determines a lot about development and behavior. And this all happens during pregnancy. So that's pretty interesting. So during childhood, prior to puberty, um, the hypothalamic pituitary gonadal axis is asleep, basically. Not a whole lot going on. Puberty is a time, it's a big change where a child develops into an adult, and that is physical, emotional, and cognitive. And it all starts in the hypothalamus. So we're back to our endocrine talk again. Not sure how you feel about that. It starts in the hypothalamus when the hypothalamus releases gonadotropin releasing hormone. And if you remember back to our endocrine lecture, there are different patterns to how hormones can be released. This is in a pulsatile manner. So kind of comes on gradually and starts this process. Now, the timing of puberty has multiple factors. Some of it is gene signaling. So, it's very dependent on if you asked your parents kind of like when they went through certain things. Like women, if you asked your mom, when did you get your period? You're probably gonna get your period around the same time that they did. Of course, that's not the only thing that influences it. Nutrition has a huge impact on this with leptin and insulin levels, and body fat percentage and overall energy availability. So, um, I remember hearing a pediatrician once say, like, oh, yeah, girls usually get their periods when they hit 100 pounds. And I think that that was very anecdotal. So I'm not going to be like, oh, I'm not going to create a test question around that. But this was a pretty experienced pediatrician, and this had held to be pretty true for her. And at the time she said that, I thought it was some kind of weird superstition. But really, kind of the whole point of someone's body changing into its adult form is to reproduce. Reproduction is a very energy consuming activity, to make a baby, to grow a baby, to support a baby. So generally speaking, you need a lot of bodily resources to do that. So that's kind of, I think, what's behind that whole weight thing, and science backs that up. And environmental cues and stress, you could do a lot of reading about this if you chose to go down that rabbit hole about the timing of puberty and how that has changed in the past, probably 100 years with industrialization and our food sources coming from different places. Do you remember when we talked about obesity and obesogens? There's a lot to do with that and how our environment kind of affects some of that signaling. So it's a very complex process, the timing of puberty. And we're back to talking about the anterior pituitary gland. So remember, the hypothalamus is that big top manager, and it makes all those releasing hormones. So that gonadotropin releasing hormone pulses, and those little pulses get to the anterior pituitary, which stimulates release of luteinizing hormone, which is going to help produce testosterone in males, but in females, it's going to be estrogen and follicle stimulating hormone, which brings about gametogenesis, so sperm production and development of follicles. And follicles are basically the little sacs in the ovaries that contain eggs. Um, in males, luteinizing hormone acts on something called Leydig cells to produce testosterone, and follicle stimulating hormone acts on Sertoli cells to make sperm. These must be named after some important people. And that process is called spermatogenesis. And we'll talk about that more in a further lecture. Testosterone's role is to grow the penis, the testes, the scrotum. Also, it's what deepens the voice, it's what increases muscle mass. That's why males have an easier time putting on muscles than females, and also produces facial and body hair. Testosterone is also really important for bone growth and closure of the epiphyseal plates. So, um, that's why men tend to not get osteoporosis at the same rate that women do because they have more testosterone. So, estrogen and progesterone, to put it simply, their role is developing breasts, uterine growth, and hip widening. They both play a role in menstruation, and they also really affect body fat accumulation. So, there's big differences in the way that women um, tend to gain weight and how their fat distributes throughout the body pre and post menopause and pre and post puberty as well. So, just a little summary of endocrine control. The hypothalamus kind of has the start of that whole gonadotropin releasing hormone pulse, trickles into the anterior pituitary gland, which releases the luteinizing hormone and follicle stimulating hormone. So, remember, the targets of those are the gonads, so either the testes or the ovaries. And then those gonads produce either testosterone or estrogen, progesterone too. And that is what's responsible for the development of secondary sex characteristics and reproductive capability. And they have a whole feedback loop to the hypothalamus and the pituitary. So, little bit about female anatomy. Not sure if those of you taking AMP2, if you've discussed it yet, but let's go over it a little bit right here. So, um, first we have the ovaries, and the whole purpose of the ovaries is to produce and release eggs and to secrete female sex hormones like estrogen and progesterone. Now, females are born with every egg that they'll ever have in their life. So, um, even in your mother's womb, you already had all the eggs that you would ever have. You already contained that if you're a female, you already contained the eggs that would, bring about your children. Kind of interesting, I think very cool, in my opinion. So Then it's just a matter with females of those eggs maturing. Um, Now, estrogen promotes secondary sex characteristics. Like I said, it also promotes endometrial growth, so the lining of the uterus, and then progesterone prepares the uterus for implantation. So they all come from the ovaries. Then we have fallopian tubes, which are connected to the ovaries, and their whole purpose is transporting an egg at ovulation. So typically, when a woman ovulates, it's only one egg. There are situations where a woman has ovulates and there are two eggs that are secreted, uh, and that's one of the ways that twins can come about. But that is not the more common situation. And then there are things with reproductive technologies and even triplets, but typically it's just one once a month. So then we have fimbriae inside those fallopian tubes, and they sweep the egg into the tube. And then, remember, we talked about cilia in the pulmonary system. We also have cilia there. And we have smooth muscle contractions that move that egg into the uterus. So, at the widest part of the tube called the ampulla, that's where fertilization takes place if it's going to happen. And, maybe some of you all have heard of an ectopic pregnancy. That happens when that egg gets fertilized and it doesn't get swept into the uterus, and it grows in the fallopian tube, and sadly it can never be viable. So, and it's a huge threat to life. That's probably a topic for another day, but that kind of puts into perspective the purpose of the fallopian tube. I thought that might be helpful. Then we have the uterus. So the purpose of the uterus is to house and nourish a developing embryo and fetus. So that's where the baby grows. And we have a couple portions of that. We have the fundus at the top, and that is where the embryo implants. We have the body, that is the main muscular portion, which is called the myometrium, and that is the part that contracts during labor. And then we have the endometrium, which we'll be talking quite a bit about today. That is the inner lining of the uterus, and it's the part that estrogen and progesterone really influence to make it nice and thick. It's a nice little thick, bed for a baby, is kind of how I think about it. And if that baby does not get conceived during a cycle, then that lining, that endometrial lining, will go away. And that's what we call menstruation. And then we have the cervix, which is a part of the uterus. It's not a separate part. It's the lower narrow part, and it opens into the vagina. And the cervix is really important because it produces mucus, and that mucus changes consistency throughout the menstrual cycle. And that mucus really facilitates um, fertilization because it can either help the sperm swim along to their goal, or it can keep the sperm out, just all based on its consistency. And then we have the vagina, which is the passageway for menstrual flow, the site of sexual intercourse, and of course, childbirth. The vagina is an acidic environment. It has a pH of 4 to 4.5, and that is to protect against infections. So it's a self-contained environment that really doesn't need like a lot of outside products. If a woman is healthy, there are like a million and one things, at the store that are all trying to sway women into like buying things to be quote unquote hygienic and this and that. But it's all a marketing ploy. So I've heard it called like a self-cleaning oven. Maybe that's a little vulgar, but it basically is. It's engineered to keep itself healthy. And then we have our external parts, labia majora, and labia minora, that's all protective. The clitoris for sexual pleasure. There's a lot of nerve endings there. We have the urethral opening, which you'll learn that again. You'll see that again in level 3 when we learn how to insert catheters. That's where we urinate from, and it is often can be like it can be tucked away. It's not always the easiest to find. The hymen is there prior to sexual intercourse, or there are things that people do like horseback riding or bike riding. So sometimes people don't have a hymen even if they haven't had vaginal intercourse. And then we have the vaginal opening right there. The female reproductive cycle. So this is the cycle that prepares the female body for potential pregnancy. And it's a pretty complicated interplay of events, and it lasts on average 28 days. A normal cycle can be anywhere from 21 to 35 days. And we'll be going, the example I'm going to use will be a 28-day cycle because it's just easier, but there really is that variability to it. The hormones that are involved in the reproductive cycle, to go over them again, estrogen, in the premenopausal woman, this is produced primarily by the ovaries in developing follicles. So remember, follicles are those little sacs for the eggs. Estrogen is also made by adipose tissue and by the liver and by the brain, but not anywhere near the amount that it is produced by the ovaries. So I'm not really going to talk about that much more, but I want you to know there are a lot of women who have had complete hysterectomies where they've had their ovaries and their uterus removed, and they still have a little bit of estrogen that comes from those other sources. Now, progesterone is produced mainly after ovulation, and it prepares and maintains the lining of the uterus. And it is almost like entirely made by the ovaries. FSH promotes growth of sacs that contain eggs, so the follicles, and luteinizing hormone triggers ovulation. So is actually what triggers that release of the egg and helps the ovaries produce progesterone. So days 1 through 5, that is the menstrual phase. So that starts on day 1 of bleeding. And this is when estrogen and progesterone are very low. And the fact that they're very low triggers the uterus to know, okay, there's no baby. Let's get rid of this uterine lining. And that's what starts that bleeding. Now, at the same time that's happening in the uterus, the ovaries are going to start, I guess you could say, picking out their follicles to develop. And that all happens under the influence of follicle stimulating hormone from the anterior pituitary gland. So it got that signal from the uterus that, there's no baby this month. We need to start working on some ovarian follicles. So then we have the follicular phase that overlaps with menstruation, and this is days 1 through 13. So that menstrual phase, like, it affects the uterine lining. There's kind of two things going on with the uterus and the ovaries. The follicular phase is happening simultaneously in the ovaries. So FSH is going to be like, hey, ovaries, start developing some of those little egg sacs that we call follicles. The estrogen levels gradually rise as those follicles develop, and a dominant follicle is going to emerge. And that dominant follicle, kind of that chosen one that's going to secrete the egg, is especially going to spur the rise in estrogen levels. Now, when the estrogen levels rise, it's going to cause negative feedback on follicle stimulating hormones. So remember, negative feedback, we're saying, okay, we have enough now, we're good. We don't need you to stimulate us anymore. And it's important that that happens because without the FSH kind of shutting off, we would have like way too many eggs being developed. And it also stimulates that endometrial lining, so that little baby cushion, to develop again because we're like, okay, maybe this will be the month that we'll get pregnant. That's, if our organs could talk, that's what they would say. So, the dominant follicle matures, the endometrium thickens in preparation for a fertilized egg to implant. And the cervical mucus becomes thin and watery, aiding sperm passage. And I really, really debated with myself whether to show you. You can do a Google image search if you'd like to see a real picture of this. It felt weird putting it in there, but here's a nice little cartoon. Um, when a woman is fertile, like very fertile, the cervical mucus will be like very crystal clear, like an egg white consistency. And then during the other parts of the cycle, it's very dry or it's sticky. But when it's clear, it actually, you could see it under a microscope. It has these like channels that just make it super duper easy for the sperm to swim on through because it comes about when there is a mature egg that is waiting to be fertilized. So in our ideal textbook menstrual cycle on day 14, ovulation occurs. And that occurs because there's a surge in luteinizing hormone from the anterior pituitary gland. And so that is kind of what gives that ultimate push for the egg to release. Estrogen is at its highest just before ovulation, and progesterone starts to rise. So that mature follicle, which is also called a Graafian follicle, ruptures. And you can see a little picture of this there in the corner. And that egg, the oocyte, gets released into the fallopian tube. The fimbriae of the fallopian tube sweep the oocyte toward the uterus, so making it closer to any sperm that have, made their way in. And they would swim on through that clear, stretchy cervical mucus. So there's that. Um, oh, I was gonna say, yeah, this is definitely day 14 is textbook ovulation day. There are many methods of trying to achieve and avoid pregnancy, specifically avoiding the one I'm going to talk about, that are based in knowing these signs, and they actually have pretty good efficacy rates when they are followed correctly. However, there was something called the calendar method people would talk about, and there were people who would literally just assume that ovulation happened on day 14. So they would think, okay, well, if we don't have sex on day 14, we're good. So you can imagine how many babies were conceived via this. So all of these dates are very, um, I'm going by a textbook formula. They can vary a lot in real life. So luteal phase, days 15 through 28. So after ovulation occurs, that ruptured follicle, because that follicle is a little sac, it just morphs itself into the corpus luteum, which is going to be the thing that secretes progesterone, and a little estrogen. So the progesterone, if the estrogen is the one that has the job of building that, uterine lining up, the progesterone is the one that's going to like kind of maintain that cushion and it's going to keep thickening it. Um, if fertilization does not occur, then that corpus luteum degenerates. That makes the hormone levels fall. And then we are back to right where we started at day one. And then that cycle just continues, continues, continues. So that is what happens if no baby. Now, if fertilization occurs, then that corpus luteum is going to hang around. And it hangs around because of something called human chorionic gonadotropin, HCG for short, which is something that the embryo produces. And that is going to sustain the progesterone and that's going to support the pregnancy. So that gives the signal like, hey, we need this progesterone so that we can keep building up this lining for the baby. And HCG is the hormone that those little, pee on a stick pregnancy tests, that is what it tests for. So, once again, if fertilization doesn't occur, the endometrial blood supply decreases, which leads to tissue breakdown. And like I said, we're back to the beginning of the menstrual cycle. Here is a little chart if you're a visual person. I know this has been very like word heavy, but here is a little illustration of exactly the rise and fall, the ovarian events, the ovarian hormone levels. So you can take a look at that and study it a little bit because it really is important to know which hormones are high and low and when and why that is. So let's move on. Since we're talking about menstruation, let's talk about the end of menstruation. Menopause historically hasn't gotten a lot of attention. Thankfully, it's getting a lot more attention and research now. But I know that I really wasn't taught all that much about menopause in really any of my schooling until I got to grad school. But menopause is the complete cessation of menstruation. It is the end of reproductive years. Women cannot make a baby after menopause. And it's diagnosed after 12 consecutive months without a menstrual period. So that consecutive part is really important because say you're a woman who believes she's in menopause, um, you have 10 months, no period, you're getting ready to throw out all your tampons, all your pads, be done with it. You start having a little tiny bit of bleeding. Well, you're not menopausal. It kind of, the count starts all over. So it has to be 12 consecutive months. Um, it typically occurs between ages 45 to 55. Much like the onset of menstruation, it is something that is very influenced by genetics. So if you are a woman whose mom went into menopause like around like 45, you likely will too. There's other factors, but it is very genetically influenced. The pathophysiology of menopause. So men, as I think we all know, they can make babies, up until the day that they drop dead at 100. They can go out and, make a baby with a young woman if they so choose. Um, Women have a finite amount of eggs. I mean, we have millions of them, but like there is a limit to how many there are. And those follicles get depleted. And over time, the number and the quality of ovarian follicles decline. And that is just due to the normal aging process. So you have to think if you have all the eggs, if a woman has all the eggs, sorry, I keep talking like everyone is a woman. That's the majority, but I know we have some men too. So please just bear with me and be patient. Um, you have to think if a woman has all the eggs she's ever going to have from the time that she is, I don't know, like just less than 8 weeks old in her mother's womb. Um, and she decides to defer trying to achieve pregnancy until late 30s, early 40s. I mean, that's not average, but it is not uncommon. Then, like some of those eggs, just like any other part of a person's body, they're going to decline in quality over time. So that continues on until menopause, and there are just less and less follicles that are stepping up to respond to the FSH. Like they're getting tired, they're degenerating. Um, so they're not responding to FSH. And they're not responding to the luteinizing hormone to like actually be developed and then, be released when those FSH and LH come knocking. And when we have fewer functioning follicles, then remember, those follicles are very responsible for producing estrogen, primarily the estradiol form. That is going to really decline. Um, Progesterone also really decreases due to the lack of ovulation because it doesn't get that signal. If you don't ovulate, it doesn't get that signal to keep maintaining the uterine lining because there's no corpus luteum. So when we lose those hormones, this whole negative feedback loop gets disruptive with the hypothalamic pituitary ovarian axis. And normally, estrogen and progesterone would say, okay, we don't need any gonadotropin releasing hormone. We don't need any FSH and LH. But when those are gone, the feedback is lost. So, in response, without hearing that message, the pituitary is just going to keep pushing out FSH and LH, especially FSH. And so they're going to stay elevated, but the ovary is not listening. So there's a complete lack of communication, and no egg is released. And eventually, like that process goes on and on and on and on to where menstruation just doesn't even occur anymore. Um, it's a pretty gradual process. I think we're learning, and I think probably because of the age I am, that's a lot of and also being in healthcare, that's a lot of the social media that I get fed is stuff about perimenopause. And also, like, I'm very interested in women's health. So I see a lot about it, and I see a lot about these studies about perimenopause. So really, this process starts years before actual menopause starts. Um, it's not an abrupt thing as people have made it sound before. So the physical effects of menopause, um, on the reproductive tract, you have thinning of the vaginal epithelium, decreased lubrication, and the uterus and the breast atrophy. So they get smaller. There is a decrease in estrogen that leads to increased bone resorption, which means the bones break down. And so there is a big risk for osteoporosis around this menopausal time. The cardiovascular system, the estrogen has a very protective effect on the cardiovascular system. And when the estrogen declines, there's a bigger risk of atherosclerosis and coronary artery disease. Just FYI, I think I haven't looked up these stats, but um, breast cancer gets a lot of attention as it should, and other things get a lot of attention, but cardiovascular disease, I believe, is the number one like medical cause of death for women over 50. And I could be misquoting that, but um, cardiovascular disease risk in women is very underrepresented, and a lot of that is due to that loss of estrogen. Um, I know a lot of us have heard of hot flashes, and it's a little mysterious, the exact mechanism, but basically, that lack of estrogen causes instability in hypothalamic temperature regulation, because that's another function of the hypothalamus. And that can lead to hot flashes and night sweats. And that's like very particular to the individual because not all women have that, but some women do. And central nervous system. So mood swings, irritability, sleep disturbances, the estrogen, these hormones really affect the brain more than people might realize. So this is why I think that hormone replacement has become so popular. There was a lot of controversy at one point due to, not to tie into EVP, but everything kind of does. But there were some really not good studies that came out, I think in the 90s and early 2000s, about cancer risk that completely misrepresented what was actually going on and kind of terrified people about hormone replacement. But now we know that estrogen has a very protective effect. Especially with the cardiovascular system. So, this can be a good option for women. But anyway, that maybe got a little out of our patho topics, but I just think it's kind of interesting to talk about and maybe helps you remember the effects of menopause a little better. Um, Here is just a little visual of the hormonal changes um, during menopause. So, like I said, if you're a visual person, maybe that will help you. Here, this is just a little overview. Of course, always go to your book and try to look up anything you want a little more information on. Um, don't hesitate to ask questions, and I look forward to talking to you about alterations in female reproduction soon. Bye bye.